Welcome. My name is Dr. Laura Burke, and I am Dean of the School of Health Sciences here at Regis College. I welcome all of our attendees here tonight, including our students, staff, and faculty, our Board of Trustees, our alums, our LARC students, and friends of the college. In particular, a warm welcome to our Sisters of St. Joseph of Boston as we celebrate our founders this week during Heritage Week. Allow me to go over a few Zoom details. This lecture is being recorded. All participants have been muted so we do not get a lot of background noise. For the first part of our time together, Professor Cifuentes will share his lecture, Don't Blame the Virus, It Was Always Us, COVID as a Social Disease. For this portion, we ask that you stop video and use speaker view for your screen. Following the lecture, we will use the remaining time to answer questions or share your comments. You are welcome to turn your videos back on then. Please use the chat box during the lecture to ask questions or offer comments you may have. Dr. Megan Gibbons will manage the chat box as questions come in. We will get to as many questions and comments as possible after the lecture. The COVID-19 pandemic has brought to life the uneven distribution of costs and benefits. Morbidity and mortality have been disproportionately high in some racial and socioeconomic groups, and the push to keep business as usual adds an additional burden to some groups while alleviates the burdens of others. Professor Cifuentes will review and evaluate epidemiological information regarding unequal distribution of COVID-19 among social subgroups and will attempt to elucidate what should have been the proper action by a more just society, a society that loves the dear neighbor. Professor Cifuentes is a medical doctor with a doctorate in epidemiology. He works in the School of Health Sciences and the School of Nursing and the School of Arts and Sciences. I think business and communications may be next on his list. His expertise in scientific research methodology, quantitative data analysis, and environmental sciences. Before becoming a researcher, Dr. Cifuentes worked as a clinician in some of the poorest rural areas of the Chilean Patagonia, as well as in the richest part of the country in the mountains of Santiago. There he experienced how workers were the canary in the mine, disproportionately exposed to the material and psychosocial hazards that affected society. The same happens in the United States. His scientific publications and presentations refer to those workers and hazards that embody the deep inequalities that pervades our societies. It is with deep pride and honor that I introduce Professor Manuel Cifuentes. Dr. Cifuentes.
Thank you, Dean Burke. Appreciate your words. We are in family now, and that is good. I would like to invite you to have an experience more than just to listen and to see slides. And for that, I want you to be at the beginning, in the middle, and at the end, because there will be some activities, as Jasmine and Nelly are currently very aware of. They are my students from Regis North. Then let us start with the first activity. And the first activity is related to this slide. Okay. And one of your duties is going to have a title for this first slide. That is something that we are going to do in a few minutes. If you have a question, please chat with Dr. Gibbons, and she will maybe collect 2 or 3, and we will do an interruption. If Dr. Gibbons thinks that it's good to do a break in between, 5-minute break, we will follow her lead about that, okay? But the first task is you have to figure out a title for this presentation. The last task is to figure out a conclusion for the presentation. And then I want to talk about all of this in detail and take as much time as needed for everybody to understand everything. And that is enough about this slide, okay?
Excuse me, Professor Cifuentes.
Yes?
Do you want to share your slides yet, or are you waiting?
I am not.
Teaser?
Oh,
not yet.
I'm very sorry.
That's
I
okay.
thought I was doing it. Thank you. Again, then, are you seeing that now?
Yes, now, yes, we can see them now. Thank you
so much. I had to do this then. Then this is the first activity, right? You have to figure out a title for this. I want to go over all of this. It's a lot. Therefore, it cannot be talked one by one. We have to put things kind of going one on top of the other. Basically, when we don't pay for our actions, as Dr. Kohler knows, we are making other people pay for our actions. Those are externalities. Then we pollute and other people get polluted. We drive very fast and other people have the crash. We generate the conditions of poverty, for example, and the violence is suffered by others. We are greedy. We don't pay a minimum wage that is a decent one. Other people get poor. And what's happening with infections? Then I want to make the case that that the epidemiological evidence in the US points that a good component, and I would say the most important one at this moment, is that the infection is secondary to racism. In fact, racism, that is very well known, is a public health crisis. More people die because of racism than for many other causes, for many other structural determinants of health. Then I want to make the case that that is happening also with COVID-19 disease, and that the virus is just one of the many mechanisms that this mortality and morbidity can take. But we are well prepared to support the virus or a bacteria or anything like Katrina, police violence, homicide, crime, dropouts, etc., that are going, because of our racist society, are going to cause morbidity, meaning diseases, and mortality. I have a few slides about the history of COVID-19. It's pretty brief, as you know. We were a well-educated planet since the year 2000. We knew that the threat of a pandemic was there, and it was a matter of when. Then we were in general well prepared, and then something happened that we didn't notice at the beginning. We were well prepared, but those who were resourceful got the resources and not the rest. And to stop a pandemic, having the resources is like trying to stop contamination in a swimming pool because somebody is peeing there, making that person peeing in just one place, not in the other places. A pandemic is a different thing, right? And then we prepare everything for our virus. Instead of, limit the expansion of the virus, we prepare everything for the virus to infect other people, to thrive, to evolve, to have other variants. Right now, I don't know how to pronounce that word. And we had international collaboration. We had task forces. Those task forces, most of them were deployed. Most of them were deployed on time. And we learned a lot about the virus. We could stop the virus a little bit at the beginning. It seemed like the thing wasn't going to expand that fact. And the most important lesson that we learned, it wasn't by contact. It wasn't about washing hands. It wasn't by droplets. It wasn't about keeping the distance or putting your elbow, the internal part, in front of your mouth. It was airborne, meaning that can float in the air for a long time, hours and hours. And therefore, there was not just a cousin, it was a different type of cousin. This is a floating cousin that can infect everybody. And then our first approach was, okay, we are going to treat very well to those who are sick. Then to the ITU, ICU, more beds, additional workers, nursing students, more hospitals, field hospitals, more floors in the hospital. Remember those initial months in which we were overwhelmed by the number of people that was sick. We didn't have enough PPE. Nurses were using trash bags instead of pants, okay? They were using fabric masks instead of surgical masks. We didn't know how to disinfect the PPE. Therefore, in YouTube, they were showing how to use the microwave. Then public health, and not the program of public health only, public health in general, started saying, okay, we have to prevent this thing. It's not enough with treating this. Many countries, the only approach that they have was we have to treat the people who are sick. Then public health said, no, you can wash your hands. This is not contact. Yeah, but it helps. Stay away. It is not droplets. Yeah, but it helps. Be quiet. Why? Because the more you sing, the more you scream, the more microscopic drops or vapor with the virus inside you exhale. Stay outdoors, ventilate the indoors as much as you can. And after 2-3 months of yes, no, sociologists fortunately told us you have to use masks. They explained and we follow suit. And then since then we have been using masks. At the beginning, the messages were very contradictory. And the problem in all of this, as I said at the beginning, that between countries, the richest countries got the resources. They had how to get the resources. And within a country, the richest counties or the richest states got the resources. Poor states didn't. And within a state, within a county, the richest towns, the richest neighborhood got the resources. And that starts telling us something. And those resources are, for example, one additional room where to stay, a room in which you can open the window. Those resources are, instead of 3 living there, only 2. Those resources are, for example, not going to the supermarket because you can pay delivery, etc., etc., etc. These resources are not, a credit card hanging in my hand. These resources are invested in generating ways to fight against the virus. And the initial distribution of resources was related to many issues. And I want to show also that that was related to race. And please, during all this presentation, if I say you, I am not saying you, Nicoletta, or you, Bill, you are right there, or you, Nina. Okay, I'm saying you, a group of people. Okay, a group of people that are with you. Okay, why? Because in epidemiological terms, we are not clinician. Groups of people are easier to compare. And we are talking of groups of people made of humans who have certain characteristics that make us different from other species. And that is an important point because only we are able to do the things that we do and looks normal. Please do not take this personally, and these 2 initial lines are very important. In every group, even all the odds are against, there are people who do pretty well. And in every group, even if all the odds are in favor, there are some people who do pretty bad. That happens. That is variability within groups. For example, we should be aware, we know in public health that poor people have poorer health, but the groups of poor people are 50% less likely to recognize that, they have poorer health. Then this myth, oh, I am part of the group people, and I got a doctoral degree, and I am a professor at Regis College, and I am an immigrant too, I am an Hispanic too. Yeah, that happens. That doesn't mean that most people in your group goes back. Okay, then this is an important thing. Let me see if I can explain with these slides a little bit more, because it's extremely important. Here we have 3 groups of people. Group in one color, another color, and another color. And if I ask you, somebody with half education, right here in the center, and half wealth, okay? I mean, somebody with half education here and half wealth here, somebody here. What is the color of that person? You cannot tell me. We cannot know, right? In this case, educational wealth are not good predictors of the color of somebody. But in this different distribution, we can clearly see that if I get 2 of these values for education, I get 1 value, for wealth, I get another value, I can immediately predict the color of the person. That is the society in which we are now. Even if we have here, for example, and here our outliers. We have our outliers, as always, everywhere, but we have most people following a pattern in which external characteristics not related to them as persona allow us to predict, in this case, their color. Okay, we let that behind, right? There are forces here that are keeping people, the same species, apart just because they have a different color. It seems, right? Now, there are 3 terms that you are going to listen again and again and again, and I am trying to explain them. Maybe I should have skipped this, but they are so used many times in public health and many times in conversation about race and discrimination and distribution of resources. And let us use health. Health can be better in some people than others. Okay, we call that inequality when that difference is not easy to prevent, or it is caused by lack of resources. There are not resources or genetic differences, things that we cannot clearly change, modify, or prevent. We talk about that in equality. We try to help everybody up. We don't have the resources or the knowledge. Another term is pretty close in letters and words is inequity. And here is different because it's also a systematic difference in health status, but it can be prevented. But our society is organized in such a way that we are not preventing, we are not treating it well, because we have cultural exclusions. For example, no, those diseases, we are not going to treat them. Corruption, poor governance. In this case, we should help, we try to help, giving more to those who need more. Okay, some do not need help. But it's secondary to a problem in our society. Now we have the issue of health due to social injustice, health injustice, if you want. And it's basically that nobody cares, or just, if you are sick, that is on purpose. They are going to die. Homeless population, we don't care, they should die soon, they are a nuisance, okay? Now, imagine that we can start saying those about elders, all people should die soon, they are a nuisance. Or people with some kind of developmental problem, okay? Purposefully, they are denied rights, purposefully. And in the best case scenario, because we are just negligent. Then we have inequality, inequity, and injustice. I try to help to understand those here. It is not easy, but in the inequality is kind of the little devil. We want, but we cannot. We don't know how to help. We don't have resources. In inequity, we have the resources, but we want to use them in other issues. And in social, because we are not organized, right? Because we have poor governance, corruption, for example. And in social injustice, we like in the way it is. If you are suffering, that is okay. That we have no problem, okay? Now, not all the cases of inequality are social justice problem, but they can be. Not all cases of inequality are inequity, but they can be. What is clear is we have a problem of social injustice, inequity and inequality can flourish if we create justice in saying basically we don't like things in the way they are. Most problems of inequity and inequality are going to be at least tackled. This is long, but I want to just mention a few. If you are a poor children, you are going to have fewer teachers, crowded classroom. You are just a poor children in an urban slum, and you are receiving this, right? That is injustice. And you are going to pay with a lot of things in addition to your health, as we will see later. If you are a youth, you are not going to have probability of a good job, well-paid job. If you're a minority worker, you are going to have a lot of safety hazards at work, reduced income. If you are a woman, you are going to be sexually abused or physically and psychologically attacked. For people forced to migrate, immigrants, okay, profound stress and security problems. For many people, unsafe food, substandard housing, illness, injury. The consequences of social injustice are large, very large. These are the social consequences. I want to show you COVID-19 as one of the, the health consequences. What about race? What is race? And then I was looking at the definition, and I found this so cynical, I'm sorry, but it says racial and national origin self-identified category. That is the operational definition of race. If you go to the concept of race, they say this is an appropriate scientific methodology that we use, but they are not primarily biological or genetic in reference, and therefore it's a social scientific methodology, grouping people by the fashion of the century. Race have changed so much. If you study race amount in the world, there are more than 200 different races. But you know, cut it out. In the US, race is skin color, accent when you talk, and national origin. All of those define a hierarchical position, a pecking order. And that is in this country. It is not, you know, 15 years ago, Newtown, I went to enroll my child in a new school. Then I was so tired of what race are you? Then I picked 2 or 3, and I was told, no, those are not your race. But I was trying to say, identify. No, your race is Hispanic or Latino. Okay. Then nobody believes on that. Everybody uses that. I think that is a bad tool, and we are not getting the problem as we should, because we are being too polite with this, or not blunt at least. And what rights are denied is very interesting that in the US, the rights are civil and political. In other countries, the rights are more related to the basic human needs, the human rights. Over here, the rights are your civil rights, your political rights, that we consider when the rights of somebody or a group of people are not respected. That difference makes me think, you know, in one case, you are seeing the person as the group, and you say your rights are violated because of your group. And then in the other, you say, oh, you are a person who is inside of a group, but you still need household food and right now. It's interesting, that distinction between the US and other countries. I truly believe that a person cannot be racist because it's a problem of definition. A system can be racist, a system. And for that system is based on social issues and cultural issues. And the cultural expressions are stories, tradition, are stereotypes, humor, and the social expression of this racism is our gender organization, our laws, our less than rules, the judiciary system, monuments that we have, celebrations that we respect. Okay, all of these things are how we have a cultural and social structure in which one group can thrive and other groups cannot, or it's much more difficult to them. But I am in those groups and I was able to thrive. Yeah, but I show you the previous slide. I showed that slide to you. There are outliers. Even if there are many outliers, the bulk, most of the group is suffering the consequences, and that is why we study groups. Then racism, okay, that is in society and culture, and then we can see that racism, our society, our culture, fits and validate bigotry, hate, the most flashy expression of supremacy, okay? And that happens at individual and group level. You have seen many videos of somebody, one color yelling at another person of another color. Everybody can be a bigot. That is important, okay? But what we see is the group in control, the dominant group, the group that acknowledges itself as the supreme group, is the one that expresses more openly bigotry, okay? For many reasons, we have some individuals doing that, but the psychological reasons are not as important as the socio-cultural reasons that are feeding that bigotry. And then we have the problem that really scares me. I am always like paranoid trying to respect everybody, but I am sure that many times I have said something wrong, okay? Sometimes I am aware that I shouldn't have used that word, I shouldn't have used that tone, that my metaphor was bad, but sometimes I am not. Then we are in this struggle. We are good people, but we cannot be perfect. And I am so afraid of being called openly. I don't know what to do, really. I don't know what to do sometimes. But is that thing that we cannot recognize well, but it's there because we have been living in this society. And we feel bad and we blame ourselves. And there are not many resources to take this away from where they are. But we try and we keep trying. And we keep trying and we want to fight against racism. We had to fight against racism and hate and bias at the three levels. One is a political fight that covers the other two. This other is, in my opinion, a culture of non-tolerance. And this is a day-to-day trying to do better. But this fits this and this, okay? Then this is the Parthenon in my last trip to Greece online. Then you have here the foundations, racism, society and culture. This is the idea. You can see it, right? It's not that easy to see, but it's here in white. And here you have the most flashy thing that you can see, and everybody thinks that this is racism. It depends on the individual, and we know it is not, but it's the expression, the flashy expression of, and here is hard for you to see. I am pretty sure because on purpose I put in a pink blank, but what is said there is basically embarrassing ignorance and prejudice. I'm sorry for that we should try to fight by ourselves. Then social injustice, referring to racism, is a social and cultural problem, and this is an important issue. Our culture is not going to change when we change our laws. Our culture provides inertia. Our culture is what we are going to say, okay? The issue also is we are victims of racism. That goes inside of our body. It hurts our body. It causes diseases. It causes stress, and it causes mental diseases, and also goes inside of our wallets and take money from there. And as the culture provides inertia, having our bodies, minds, and wallets impacted, also that causes inertia, and victims of racism suffer for generations. Imagine like victims of a war, they suffer for generations. Let us go a little bit more inside the problem of health. This is a nice study with a terrible observation. This was in Florida for many, many years, retrospective. Researchers asked the question, are black doctors or white doctors better when treating white babies? Sorry, black babies. Then when you have black physicians, here in the red dot here, 390 black baby die every 100,000, okay? That is when black physicians treat black babies. When black and white physicians treat white baby, 285 white baby dies. A little better performance by black doctors, a little better, like 5 points, a little better. Then we say here, we can see that white babies do better than black babies. And we know why. We know there are many reasons. Those reasons have been explained. They are related to 2 points, poverty. But when white physicians treat black babies, the rate of mortality goes to the roof. 890 babies, more than twice. Why? So far, there has been no explanation at all. Oh, because the white physician treats babies that are more sick. False. Black physicians treat babies that are more sick. The severity of the disease? No, that is not that. It's not the severity of the disease. So far, there is no other explanation, except that something is going on that decreases the performance of white physicians when they are treating black babies. And you know what? Eventually, this is related to this on top, because they are not purposefully hating. But this is what happens. This is what happens. And how do we know that these black physicians are good? Because when they treat white babies, 280 die with black physician and 290 die with white physician. Then these doctors do better even with white babies. This is scary. This is extremely scary. My baby is going to die because of the race of the doctor, the color of the doctor. That thing we call race. This is very scary. Then let us start with this feeling of a horrible issue that cannot be explained but using racism. You know this map, right? This is the map of the US. Here we have the West, the West, the East, the South, the North. And in this square, I tried to capture the part of the US in which the black minority is highly represented. Then I am going to use the same square over the same geographic region to show some coincidences. Coincidence number 1, mortality rates. Red is very bad, yellow is bad, blue is okay. Where is the yellow thing? Here we have some pockets, right? Let us ignore that. Look how the yellow is trapped by the same geographic area. Then in the place in which most black population is highly represented, in those places we have a high mortality rate, both sexes standardized by age. Now, life expectancy. In case of life expectancy is in the other direction, they change the color, but no, at the end, in our chart, yellow-red is bad. Where is yellow-red? In the same geographic area. What a coincidence, another coincidence. Now, alcohol, let me take this down a little bit. Alcohol use, in this case, blue is good. Look, they have more mortality, lower life expectancy, and they drink less alcohol. We have problems here on top with alcohol use. Massachusetts, Weston is okay, but look, the The areas of Massachusetts that are having problems are at the west, but not here. We don't have alcohol issues, apparently, right? Very apparently, we don't have alcohol issues. Smoking. Ooh. Smoking. Again, smoking is concentrated in the same area in which Black population is highly represented. Okay, we tend to eat. Bill and Marilu are the only person that do not eat a lot in Regis College, right? All of the rest of us, we love to eat. But they love to eat more. Look, the intense red is right here. Yeah, here they don't do that bad, but you know, they fight a lot for having the first place. Let us go again. Hypertension, red is bad. Hypertension, red is bad. Again, its focus is concentrated here. Let's continue. Diabetes. Again, we have big pockets in these counties in which very little people lives, but here we have the issue. Again, in the entire country, over there. Physical activity. Now, blue is good. Again, we are having problems again. Low physical activity. What is going on? Now, COVID death in March 11, a few days ago. We have this area with a very blue. Here, blue is bad. It's concentrated here, but A is concentrated here too, right? But here, and it's also concentrated here. The death mortality by population, the death rate, we call it. In the US, focus in these three areas. Let us take a look at the map, at the original map. This here is where Black population is highly represented. This here is where Hispanic population is highly represented. And this here is where American Indians are highly represented. Well, nobody lives there, to be honest, but you can see the point, where minorities are highly represented, especially Black population. We have higher rates of disease, or higher rates of behavior, or higher rates of mortality, or lower life expectancy. Yeah, and that is the question, right? How? Why? Who will explain this? And many social epidemiologists have been saying this for years, where Dr. Burke studied at Harvard. They have been publishing and publishing and publishing. It is racism. It is social injustices. And the biomedical community that leads, unfortunately, in this country, the public health community, is still pretty resistant and keeps trying to find biological things instead of the evident social things that are here. Now, let us talk about, instead of health inequalities, social inequality, let us talk about COVID inequality. Okay? Then we know that if you have a non-preventable chronic condition, you have disabilities, you are a male, dark skin, older. This was a compliment for myself. You are going to be in poor health to fight COVID. But this is difficult to prevent, right? But then, yeah, there are some basic inequalities. There is no money for nursing homes. There are some chronic conditions that are preventable. There are some exposures that are preventable too. If you are making little money, you are poor, you are in a disadvantage. That is preventable too. If you need to travel a lot using public transportation, therefore you are going to be in a high exposure. All of these things can be changed, but nobody gave them priority. Also, in this inequality, we have a culture, we have a system that is not necessarily against a group, but is, hey, you take care of your life. Nobody else's life is your business. It's they and we. That is, the other town is not our family. You know, that it's smaller and smaller, killing destroying the social network that can support us. And this is very dangerous happening in this country more and more. The problem of anti-science is not that you have a serious criticism, it's identity. You're anti-science, you belong to a group, okay? If you distrust and deny science, you belong to a group. If you believe that an opinion is better than a bullshit, come on, it's not better, it's an opinion. We can have educated opinion. And you know what? If you are an expert in something, in the level of evidence is the weakest evidence. In science, the opinion of an expert at the very best is going to be used to a good idea and nothing else. But we have uneducated opinions considered as valuable as facts. Research is browsing Google, and that makes us pretty weak when we have to face diseases. And that can be prevented, modified. It will take a lot of time, a lot of education, right? And more example, nobody gave in this country, it gave in other countries, workers money to stay at home. There was not enough money for businesses to close and stay without working. There was not enough money for workers to say, hey, just report early symptoms. No, do not report. If you report, you have to stay at home and you will have no money. Okay, you will lose your work. Okay, no way for taking care of our loved ones. I'm not talking about us, that many of us have a house where to stay. I'm talking those people who live many in a house. I have a student that she kept studying the entire semester, taking care of grandma and their family, and working and studying. And that is too much to put on top of a person. No help. But those things can be modified. Now, imagine that there is a pandemic disadvantage because you are poor, you have dark skin, or you are an essential worker. And those three things go together. Oh, this is against the poor. It's not racist, but that the poor is black or Hispanic. Oh, no. This is because the essential workers are showing sacrifice. Yeah, but the essential workers are mostly dark-skinned and poor. Let me show you, please, the information, the evidence that I have collected about that. But let us jump with this idea in mind. We do not have a society because it came from a tree or from the sky. There is a spider, or there are spiders making the web of our society. And we don't have to be disingenuous. We have an idea of who that spider is. Maybe not the names, but we know what we are keeping well and prospering because we accept our society in the way it is. Okay, this is a ugly, very ugly slide. I don't like it that much because it still has too much content. But let us focus here. The fourth is worse than the third, which is worse than the second, which is worse than the first. You want to be in the first social risk score. The fourth is the worst of the worst, the worst of the worst, because there is more poverty on those towns, there is lower income, lower insurance coverage, more unemployment, and more essential workers. If you are in a town that is poorer, have lower income in general, have lower insurance coverage in general, more unemployment and more essential workers, those towns are going to have a rate of COVID that is going to be, let me see, more, it's higher, that is twice as much as those towns that are in better shape. The town containing more essential workers is suffering more. And that is go with poverty hand by hand with lower insurance coverage and employment. That is a fair thing. And this is a study published a few months in July. Okay, these are 3 months, May, June, and June. So three measures. And independent of the 3 measures, if you have a lower social risk, if you are in a town that is poor, low income, lower insurance coverage, you have more COVID. But why? The virus doesn't discriminate, right? Oh, it does. And this is about occupations. If you are working healthcare and social assistance, I mean towns, 36% more COVID. If you work in transportation, 109% more COVID. If you work in service industry, 79% more COVID. If you work in healthcare support, 73% more COVID. Occupations, in some occupations, there is more COVID. And look at occupation, transportation, healthcare, service, those are essential workers. Now, the census says that Black and 13% of the population. And we look at all healthcare workers, Black people are 16% of the population. A little bit more, not that much, right? It's okay. But when we look at these 3 groups that are exposed because of the group, aides and personal care, direct contact support workers, social workers and behavioral health workers. Social workers have to visit houses and talk with patients that are in crisis. Behavioral health workers, they have to be face-to-face. It's not enough just to talk using COVID. In all these 3 groups, Black population are well overrepresented. It should be 13 or maybe 16, but they are 30, 22, 20. They are overrepresented in those groups in which the possibility of getting not just attacked by a patient that is having troubles, attacked by a virus too, or a bacteria. You know, that is what I say, do not blame the virus. We are preparing this. We have been preparing this soup for a long time. Then we knew the first healthcare workers are always at increased risk for COVID-19 infection, but certain healthcare workers are particular high risk. I just show you what. And the CDC, oh, what a novelty. 53% of confirmed cases were among people of color. Yeah, because of this. Because of that, they are not most of the population. They are at the most 40%. At 40% got 53% of the cases. I mean, the entire people of color are 40%, but they get 53% of the case. Now, the blue is essential industry. Black should be 13, 44. Hispanic should be around 45. Native American, 45. Minorities are overrepresented in essential industry. Blue is working in personal and close to other. Minorities are overrepresented while working as essential workers close to others, in person and close to others, face to face, close, in person. Here doesn't really matter the color. In person, look at the orange thing. White, 10% of whites, okay, are working close to others. 16, 28, 28. Minorities again, they are more exposed to the things that are dangerous. Now, working in close proximity to others, those who work in public transit to commute, to use public transit to commute to work. You know, they use public transit to commute to work and work in close proximity to others. Again, they are overrepresented in comparison to the dominant population. This is not casualty. So this is not casual. This is a casualty. This population is a casualty. Now, what we have here, this is important because imagine you have many reasons to get the virus. You go home, and while you stay at home, you have more people living with you, that can get the virus. And this is multiple adult generation. Basically, grandma is living there, right? And again, higher population, higher number. When I show things like this, the immediate content is, oh, this can be a cultural issue. Yep, this is a cultural issue, right? We can be Asian doing the same thing than Hispanic. That doesn't mean that we had to go through this cultural issue living in a 2-bedroom apartment. That happened. What do I mean? If we look at let us say, to do it short, green is good because you are living in a single unit. White, more than 80% living in a single unit, like Native American, more than 80%. I am surprised by this. But minorities are living not in a single unit. Most of them live in these apartments, right, with 10 or plus units. No, not most of them. There is an important portion that lives in multiple units, residences. I don't know how to, yeah. There are 3 types of residences, and good portion live in multiple unit residences. They don't live in one. It is better quality of life. Then at the beginning, we talk like we have a population that in this country, in which we have some reasons to think that there is racism. We have seen inequality in action affecting health. We have seen inequality in action affecting COVID health. We have seen occupation. We have seen, in this case, a little view of residency. All of these factors were here before COVID, right? We know that people with COVID are at high risk. People with this race, with this poverty, are at high risk. We know that part. We knew that they were getting the disease more than others. We learned that those were minorities that were highly impacted. And we were surprised at the beginning, and then the news disappeared from this. Was not a novelty anymore. Now we are invited to vaccinate ourselves, to receive a vaccine. And then there is a list of diseases that are high priority. And it's a list of 12 conditions, no diseases. And then I decided to study, okay, let us study cancer and race. Blue is black. The rate of cancer, in this case mortality, is consistently highest in the black population. Let us, number 2, chronic kidney disease. 4 times more likely to die for kidney failure, black population. But we are in the condition number 2. Condition number 3, COPD. Oh, more white people die of COPD. However, black people have between 50 and 300% underdiagnosed of COPD. That is very well known. Number 4, Down syndrome. All races have the same incidence of Down syndrome, but the life expectancy of children with Down syndrome is 25 years for blacks, 50 years for whites, 10 years for Hispanic. Any clue? Again and again and again. Heart disease, number 5. much higher for a long time in the Black population. It has gone down in all groups, but keep being higher. Immunocompromised, oh, this is clearly higher in white, okay? 3% in comparison to 2.25%. Obesity and severe obesity, Black, again, 49%. Only Asian have a clearly lower rate. Number 8, what is this? Pregnancy, right? Yeah, this is pregnancy. Then let us see the birth rate, that is an indicator of pregnancy, of course. Black on African American, 52. Minorities tend to have a higher pregnancy rate, birth rate in this case, okay? Slightly higher than the other populations. They are above average in this. Sickle cell disease, that is a characteristic type of red blood cell that affects 100,000 people in the US. Almost all of them are Black, 99.999% are Black, okay? They are an exception. Smoking, African Americans smoke much more than the other groups. Only this group smoke more, but in comparison to the other group, I mean the Hispanic and the non-Hispanic Y, African American smoke a little bit higher than non-Hispanic Y. But you know, the smoking rates that we see in the map, it was much higher here. Maybe that was the tobacco industry. I don't know really at this moment, but they are not in second place. They are still in first place. Number 11, diabetes, Black, Hispanic, white. Asthma, Black, American Indian, and this is white. Then we have our 12 conditions, and in 10 of them, maybe 9, if we want to give a tie here or there, the Black population is above the average population. Okay, but those 12 things were to recommend people to be vaccinated as soon as they can, right? I want to go here. I don't know how to go here. Then let's go to this web page. I have to share with you this web page. And okay, we see that the Black population is a high risk when they get COVID. And then this is the Black population vaccination rate. This is the percent of cases, 29% in Alabama. They are receiving 19% of the vaccination. Look, 30% of death, 29% of cases, 19% of vaccination. And we know that they are at high risk in Alabama, in the District of Columbia, with a large Black population, right? 49% of cases, 76% of them, only 26% of the vaccines. Massachusetts, 8% of cases, 7% of death, only 6% of mortality. Even not one-to-one, it should be larger, much larger. Not, what do you want to see? I'm going to give you the presentation so you can get New York. I don't know, this is weird, this 0%. 23% of mortality, 8%. Then what is going on? What can be the explanation for this? That can be a rational explanation of this situation. I am thinking that this is on purpose. Look, poverty rate. Poverty rate, this is the black group in comparison with the purple non-Hispanic white group. In the 70s, 4.8 times higher, the poverty rate for black population. 3.7 times higher in the 80s. At the beginning of 2000, 2.8 times. At the beginning, it was here, at the beginning of 2010 and 2020, of the decade, 2.6 times. And then everything went down since 2014, more or less. Okay, poverty rate went down for all groups. What is the poverty rate now in comparison to the white group? 2.6 times higher. The change has been absolute but not relative. There is an important thing going on that keeps this distance for 20 years. Then it is race that they are more affected by COVID, they die more because of COVID, they receive less vaccines because of COVID. Then the way I figure out how to do a comparison is to do some international comparisons, because please believe me, there is people that is black living outside the US. And look at, there are parts of the world, poor countries here in Africa, right? A couple in South America, in the Caribbean region, in Asia, here a small island, a big island, that report low rates of COVID. I mean death. If we compare the continents, I split the European Union and Europe, okay? We can see that there is a group of people doing pretty bad here on top. We know some of this. South America is doing bad, but others are in the green area and they are doing okay. It seems so. We split by countries and we see that there are very popular countries here on top. And then look at the countries here down, India, Zimbabwe, Asia, or Asian continent, or the African continent, China, Vietnam, Tanzania. What? Couldn't you see the slides?
We just lost the slides.
No, it's okay, because
Okay.
I noticed that I wasn't presenting properly. Then I am trying again, okay?
Okay.
Thank you. Now?
Yes, that's better. It's bigger again. Thank you.
Before, what were you looking at?
We could see presenter mode, so we could see the next slide and everything was smaller.
Okay, that wasn't a problem. Yeah, but
Yep.
Thank you. Then here we have some countries, and we have a cluster of countries that stay here. Another stay here in the green zone, okay, in the green area. Here in the green area. Then we go to the green area and we see that South Africa and Tunisia went up, but they don't go to the red area. These are the worst countries in Africa. We have Morocco, that is pretty close to Tunisia. Botswana, Zimbabwe, Equatorial Guinea, they are doing pretty well, looks like. But you know what? I can add other countries that are not from Africa or Asia, like Australia and New Zealand, they are doing also well. It doesn't look like doing well is a matter of race. It doesn't seem that doing poorly in the US because you are black is a matter of race, because you have a lot of people that are black in Africa and they are doing pretty well. Why in Africa? The African puzzle. Oh, because they are too young. No. that was adjusted by age, and the rate is still low. They have acquired immunity because they are infected for so many things. There is no evidence of that so far. Oh, there is underreporting. Only one study in Zambia inconclusive about underreporting. These are death rates. You count your death pretty well. Additionally, when we talk about death rates, we can see an increase in mortality like we have seen here in the US with hundreds of people, former people waiting to be put on ground or incinerated. We haven't seen that in Africa, Australia, New Zealand, and many countries in Asia. It's not that. Three things that I want to mention. This country has problems with identity that are affecting the epidemiology of a disease and many diseases. Christian nationalism goes hand by hand with anti-vaccine, anti-science attitude because we are God-chosen people. This is critical for the future of the vaccination campaign in the US. They are not going to get vaccine. Black population also have the same issue here. They don't want to get vaccination in general, okay? But when they receive information, they change their opinion because they have been historically abused and they are fearful. And additionally, many of them want to be vaccinated, but they don't have access. It has been shown with the flu shot in Medicare and with campaigns going to the neighborhood. It has been shown that when we provide them with access, they get vaccinated at the same rate than white population. Then it seems a problem of access mostly, and also a problem of hesitancy because I don't trust you. And we know that most cases of viral epidemic diseases, for example, flu, have happened in people who have not been vaccinated. Then what is going to happen in those cases of COVID disease that at the end of the year or next year, it's going to happen in communities that didn't receive the vaccine. I hope I talk about this. And this is my last slide. We have the soup ready to go. The virus just came and did what the little thing knew how to do. I don't know if we do have some time.
We do. We have 15 minutes, so we can invite people to ask questions or offer comments. And the best way to do that might be to just unmute yourself or to let me know in the chat that you'd like to share something.
Manuel, a quick question, if I may, sir. Thank you for that. Very thorough analysis of every piece of evidence we could find that points to racism in healthcare outcomes and life outcomes. How do you disentangle the sort of proximate healthcare issues from the ultimate racial issues? Is, I guess, my fundamental question, if you know what I'm asking.
You mean race is a social determinant of health that is far from I have two approaches to that. One is a public health approach, then is what proximal indicator, health indicator, is a characteristic of the race, and none is a characteristic of the race. This is a cluster of diseases that happens more frequently on people with Black race. Then from a public health perspective, instead of separating one or the other, I I would say we cannot change the race. Therefore, we have to do the prevention to those proximal factors. Then I wouldn't say that disentangling will be the approach I will take from a public health perspective. From an epidemiological perspective, playing with math, I would like to know whether these diseases that are proximal act like a mediator, and thinking that there is another direct effect from a special characteristic of, for example, Black people from race connecting to COVID at the end. Then I will do a mediation analysis. I don't know if I went too much into the details and I escaped from your question.
Manuel, hi, it's Elizabeth, and I don't want to turn, and Bill, I don't want to turn on my camera because I worked out and it's not pretty. So I did a little bit of work on this, actually quite a bit. And what I found, what my work showed was that once you standardize for everything, there's still differences left over that you can only attribute to really racism. And that was for, you know, particular population. It was the US population, the AHRQ data. And I'm sure probably something like that is occurring with the pandemic as well.
Mm-hmm. Thank you, Elizabeth. Yeah. Then you have tried to control for every other possible reason.
Yeah.
And by that, there is causality left that has to be attributed to things like racism.
Yeah, that was my thesis, was that it could be. It's not, no one, the questionnaire did not say to the provider, are you a racist? So the only way around that is to measure the level of care using a proxy, something like hospital nights or expenditures or whatever it may be, and then measure the access to care by those numbers, and then attribute the differences, which were substantial, especially between Black women and non-Black women, attribute that to racism. I posit that, I can't prove it, but that's what.
Yeah. The only way to prove this will be an experiment in which we put babies randomly assigned with one race or another and see what happens to them, right?
Yeah, there's an ethical issue with that, I think. But that was great. It was right up my alley. I really enjoyed it.
Thank you. I would like, please, to invite everybody, and let us use the chat. I was thinking about using Jamboard and other tools, but let us use the chat. What will be two things? A nice title and a nice conclusion for this. Because I talked Marilu about a title and she said, Manuel, you should imagine that. And then I said, okay, I need help. What will be a nice title for a presentation like Nicolette? The tip of the iceberg. I am terrible at titles. I don't think that will work, Kate.
Manuel?
Lucia?
Hi, Manuel. This is Lucia. And I'm, thank you so much. It's, again, I second what it's been said about the thoroughness of your presentation. And I kept thinking about Paul Farmer and his work and his research, and which basically concludes that poverty is basically at the top of the list in terms of what the crisis in public health around the world. And I mean, I don't know anything about Paul Farmer and whether he speaks about this also from the racial point of view. Does he actually present this from this perspective that you're presenting, from the racial perspective?
Mhm.
That's my question or my comment.
It wouldn't be that poverty is a way to submit those groups that we are interested in keeping them subservient?
Well, and what leads to poverty, basically,
Mhm.
right? But which is what Farmer argues. I'm just wondering if he actually has written, I don't know, about race as say equal to poverty or on the top of the list. I'm thinking not only race as an issue affecting
Okay.
those in COVID in the United States, but throughout the world.
A couple of health economists, like two, I don't remember the names now, but I read the paper 2 or 3 weeks ago, were showing that poverty is a condition that makes people more similar or equally similar than race. I mean, if you are equally poor, you have the same life expectancy if you are white or black. If you are equally rich, you have the same life expectancy if you are white or black. Then they say it is income, it is not race. And having understood that, we have 7% of poverty in white and almost 20% of poverty in black. Then, yeah, I can understand. And that sounds pretty logic, right? Why the poverty rate is higher in black? I believe that is basically we have a racist society, racist culture. That is one thing. And another thing, we have a problem of identity in which the poor black and the poor white think about themselves differently. One still think about being in the supreme race. And that cause is so easy to exploit them, the poor people, because they fight among them instead of noticing that they are being exploited by others. Yeah, that would be my comment. Poverty is important, but still black people are 2.6 times poorer than white people.
Yeah, thank you.
Just a quick point to add on what you just said, Manuel. When you look at the differences, not just in income, but especially in wealth, then it's even a larger distinction.
Yeah. Yeah.
You can't steal ideas from other people, but sometimes they make things very succinct. I went to a talk by Professor Cifuentes at Princeton, and the title of his talk was "Race is not the risk factor, racism is," and then breaking it down that way. So thinking more in terms of the behavior, because race is not a biological reality. It's a social construction that we have created. And so it's the ideology and the judgment and the valuing in unfair and inaccurate ways. Just a thought.
And our structure, our society is racist. We are hateful people. We are bigots. But we are not that powerful to be racist. That distinction is important because if we do not make that distinction, we will have, as we have seen in the last years, many years, racism if a few people doing racist things. That is the problem. We have to educate them. No. They are the expression of something larger and bigger. And that distinction, I like to emphasize that distinction a lot. It's not about people screaming at others any word No, we living our lives and applying in a way we know causes disadvantages for other populations. Then it's not enough to say I am not racist. Of course, that is not even the minimum. The minimum should be, as I learned yesterday presentation, that with grace and okay, that we should be anti-racist. That should be the new minimum. That should be the very, very new minimum. If you are not anti-racist, you are not even fitting in what is normal. That will be my contribution. To give 1 minute, Dr. Gibbons.
Well, I don't know if we've come up with a title yet,
There is
Manuel,
many excellent ideas.
but the title we had was good. And it certainly spoke to your lecture, which was just tremendous. So much work went into this lecture. So we're all very appreciative of the time and effort you put forth in creating this this presentation for all of us. Certainly enlightening. It's been wonderful to have so many people show up on a Tuesday night and be a part of this conversation. So thank you. Thank you so much, everybody. Thank you, Manuel. Thank you, everybody, for participating and being present tonight.
Thanks, Manuel.
Thank you, Bill.
Have a
Thank
good
you, Manuel.
have a good
Gracias.
night, everybody. Thank you.
Gracias.
Thank you.